Hey guys, so we got another great session coming up. Greg Berlet from Ohio is going to be giving this, moderating this session. So Greg, it's all yours.
All right, thanks, Lee. This session is called "Cracking the Code of Ankle Pain," and it's really focusing on troublesome ankles where patient hurts. It's not always obvious what's going on, and our expert panel of Justin Tsai, Adam Bitterman, Rabun Fox, and I are going to kind of tease it apart. Our format is 4 talks, and then we'll do Q&A at the end. So if you have questions, just pop them in the chat box. All right, we are going to start with Justin.
All right. Hello, everyone. So as part of our series on painful total ankle today, I'll be focusing specifically on gutter impingement. My name is Justin Tsai. I'm an orthopedic foot and ankle surgeon based out of Staten Island, New York City. Here are my disclosures. So impingement, as we all know, can be a cause of postoperative pain after an ankle replacement. And we can broadly define these into symptoms that occur pretty much right after surgery. And usually this is secondary to a technique issue, whether it's a oversized component or inadequate debridement of distal tibia bone. In these cases, preoperative CT can be tremendously helpful. Nowadays, there's several systems where you can overlay projected implants overlying the patient's bone. And so you can go into the case with kind of an idea which size you're going to use and particular areas of the patient's anatomy that might be tricky. So it can certainly help, but it's not foolproof. And of course, one must always rely on kind of what they're looking at. Delayed presentation would be things like arthrofibrosis or heterotopic bone formation. Sometimes a component that is well put in originally but subsides can then become a cause of impingement. This is one of the larger studies focusing specifically on the incidence or prevalence of impingement. This was a single surgeon study done over the course of 11 years in which 4 different implants were utilized. They looked at whether prophylactic gutter debridement was performed or not. And the outcome in this case was whether the patients had to subsequently go back for an operation to address impingement. And you can see here with the red box that basically in those patients that did not have a primary or prophylactic gutter debridement, they were almost more than 3 times as likely percentage-wise to have to undergo a secondary reoperation as opposed to those that did have a gutter debridement done. There's been studies done recently, not looking specifically at impingement, but looking at outcomes. And as part of those studies, they looked at the incidence of impingement. So recently, a group out of HSS looked at the midterm outcomes of the Infinity implant, which is a 4th-generation fixed-bearing, low-profile design. These patients had a minimum of 5-year follow-up, and there were 65 ankles in this group. The minimum follow-up 6.5 years. They found that there were 2 patients in their cohort that had to undergo gutter debridement, which yields about a 3% percentage. This is pretty much in line with those patients in the prior study that had a prophylactic gutter debridement performed. In a similar manner, this is another midterm study looking at the Inbone 2, which is a fixed-bearing implant, flat-cut tailless modular tibial stem. Again, these patients had a minimum of 5-year follow-up with a mean follow-up of 6.4 years. We had 1 patient in this group that needed an open gutter debridement, yielding again about between a 2 and 3% incidence rate. And finally, this study looked at the Inbone 2 and Salto. There were double the amount of Salto cases, but they did find that overall there was a higher reoperation rate in the Salto cohort compared to the Inbone 2. And they found that actually the majority of these cases were caused by gutter impingement. And not surprisingly, these patients actually did worse functionally. There was no clear reason why this happened. The theory is this could be secondary to a difference in design, specifically the talus. In the Salto, you'll see on the left-hand side, there is a talar component that has 2 different radii of curvature, larger on the lateral side and smaller on the medial side. And there's thought that this incongruity, this can cause incongruity between the talus and polyethylene, thereby leading to third body wear and heterotopic bone formation. But again, we're still not sure why this happened in this case. And so, Dr. Volcano and Myerson put out this nice algorithm in terms of working up a total ankle, and all kind of painful total ankle, I should say, but I'll focus specifically on the portion talking about impingement. And so the first clue is, physical exam and where the patient is localizing their pain. This can be difficult given the small footprint of the ankle and how close everything is. But if they're pointing at their gutter and you're suspecting gutter impingement, then that's a relatively concrete first sign. You can look at obvious signs on X-ray, such as oversized implants, subsidence, heterotopic bone. Of course, one always has to rule out infection. And then once you kind of have an idea or suspicion what's going on, an injection of local anesthetic can be quite useful. If you inject into the joint on the ultrasound or without, and they get a good response, then one can fairly assume that this is kind of indeed what's going on. And lastly, advanced imaging can be helpful. CT scan allows you to see what you can't see with X-ray. You can look at axial views, which can help you determine whether this is a malpositioned talar or tibial implant. MRI can help rule out stuff around the ankle, such as soft tissues that could be contributing to pain. And lastly, SPECT CT, which I'll talk about here, can be useful as well. SPECT CT is an imaging modality that combines the functional benefit of scintigraphy with the anatomic resolution of CT scan. And there was a nice study put out by the physicians over at HSS that looked at how well these two correlated. They took the patient's clinical exam and intraoperative findings and saw how well this matched up with what they saw on SPECT CT. And the result is that they were very well correlated. So about 89% correlation rate between SPECT CT findings, ankle findings, and 93% correlation between SPECT CT and intraoperative findings. This is an example on the right side here. You'll see how kind of SPECT CT lights up kind of in the medial gutter, and this kind of confirmed or matched with the clinical exam findings of pain at the medial gutter and suspicion of medial gutter impingement. In a similar matter here on the left-hand side, there was a clinical suspicion of medial gutter impingement and subtalar joint arthritis, which was correlated with the SPECT CT. And on the right-hand side here, again, lateral gutter impingement suspected and confirmed or at least correlated on the SPECT CT. Interestingly enough, they noted that this patient, even though one might suggest based on the SPECT CT that they had loosening of the talar component, this was not the case. Lastly, I'll talk about treatment. This group out of Duke kind of put out a nice algorithm and described their techniques. So I'll kind of go through this. They looked at 75 patients that underwent surgery to treat impingement, and they divided these or separated these into those treated open or arthroscopically. Sometimes they had both. The main determinant used in this case to determine whether they would undergo either open or arthroscopic was if other procedures had to be done. So there was extensive work that had to be done outside of the debridement, then they opted for an open procedure. And this is for obvious reasons. It takes longer. This is a difficult scope, and you don't want fluid kind of getting everywhere in the soft tissues and kind of making it difficult to find your tissue planes. And therefore, there were more likely other procedures, then they opted to go ahead and do it open. So in terms of an open treatment, anterior approach or a portion of the anterior approach was utilized. They were anticipating doing a poly exchange. This allows one to get to the posterior capsule and debride that as well too. Otherwise, if that was not planned, then one could do a targeted lateral and medial debridement or approach to the debridement. You want to have things like rongeurs, curettes, osteotomes on hand. Pituitary rongeur I found to be particularly useful, not only for secondary operation, but primarily just to be able to get back to that posterior bone, especially when you have a tight space you're working with. Arthroscopically, you could start with your typical anterolateral intermedial portal, maybe a posterolateral portal if you need to get back posteriorly. 3.5 shaver is kind of the sweet spot. And it lets you kind of get at the scar tissue there fairly aggressively, but sometimes you need to go smaller. You want to have a burr, curettes, and a radiofrequency ablator on hand as well too. And you can judge how adequate your debridement is based on how visible or whether you can visualize the posterior structure. So on the medial side, it's the post-tib tendon, and lateral side, the peroneal tendons. So lastly, this is kind of just an algorithm where there are pearls right here. So you want to keep the hood of the burr against the prosthesis. Top left picture, you'll see that over here, where the teeth of the burr is kind of facing toward the medial malleolus, where you see the metal implant, talus implant on the left side. And you want to start by using a curette to loosen up the soft tissues to allow the shaver to kind of do its job. And the idea is to start from anterior to posterior. So you start from what you can see and move toward what you can't see. and you work your way all the way to the back till you encounter that last bit of bone before you get into the soft tissue. And the way to describe a safe way to get through this is by using a drill bit to kind of fenestrate that shelf, which you'll see on the bottom left there. That's a 3.2 drill bit kind of making multiple holes in that shelf. And then on the top right, you see them using a right angle curette to kind of break through that until finally on the bottom right, you could see the visible posted tendon. And they found that, in contrast to the prior, that their rates of impingement were actually less in the soft toe compared to the inbone or star. In general, it took about 2.5 years for them to take these patients back for debridement, but they had good results. About 89% were still asymptomatic after debridement, so with at least 1 year follow-up. They did find that as a trend, more patients that had arthroscopic debridement ended up needing a subsequent debridement compared to the open side, but this was not significant. And lastly, both saw improvements in pain and functional scores. So in summary, preoperative templating is key. Performing a primary gut debridement at time of index surgery is absolutely essential in preventing a take-back for this. And SPECT CT can be a powerful tool in combination with clinical findings, and arthroscopic and open techniques are both valid. Thank you.
That's great, Justin. Got a few questions for you when we get there.
Sure.
Adam, can you help us understand the tibia and where that might fit into sorting out this troublesome ankle?
Absolutely. I will do my best. So I have been tasked by Dr. Berlet to talk about the loose tibia, and I want to thank him for the invitation and also thank Dr. Parekh. Disclosures here, unrelated to ankle replacements. And so a loose tibia can come in many different shapes, sizes, and may be subtle or may be quite obvious. It can affect implants from the modern day or the implants that I remember learning about as a med student or even as a resident. And you can see that scope from the left where it's slightly visible. Now that we're talking about a loose tibia, everybody's obviously biased and turning their eyes directly to the tibia. That central image is clear as day, as is the image on the right. And so the question is, what do we do about a loose tibia? How do we know if it's clinically relevant? And of course, if we see it, why did it happen? And then there's also a situation like this, where the question is, was the tibia loose prior to the injury? Was the tibia loose as a result of the injury? And is there something that could have been done differently? Now, what else would I rather be doing on a Saturday afternoon than talking about the sexiest procedure that we have in foot and ankle, the total ankle replacement, and when something goes awry? And we have to keep that in mind, that we are not perfect and certainly need to have that conversation with the patient consistently. And I know that Dr. Tsai talked about a little bit of this, but the reasons that total ankles can fail from a general standpoint is seen here. This is not every possible reason, but this is most of the most common reasons that are seen. The bone may be abnormal prior to you agreeing to do a total ankle replacement, and that may lead to cysts after the fact. Infection, instability with soft tissues, mechanical failure, whether that be user error or patient-induced error, aseptic loosening, fractures before the surgery, during the surgery, or even after the surgery. The cysts, as mentioned before. Even with all these advanced tests, we can sometimes predict good bone, but we may encounter bad bone, or the bone may decline over time for a variety of patient-related factors. Patients can be unhappy with stiffness. They can be unhappy with impingement, soft tissue imbalance. If we're not fully correcting it during the surgery, it may lead to a failure. Obviously, the wound, the poly, and then improper sizing, overstuffing, or underutilizing the space available. So the tibial cysts, well, why do they happen? If they are there on pre-op CT, we should be able to get rid of them. Is it due to third body wear, where the poly breaks down, you get fancy biochemical reactions, thus leading to HO and or cyst formation, cyst migration, cyst enlargement, and then just lysis as well. As good as we think we are, we don't always have a clear-cut answer, but certainly these need to be addressed. How they get addressed? Well, there's certainly a wide variety of treatment options. So what's the deal? Well, when you attack these, you don't want to bury your head in the sand, and you certainly don't want to avoid them. You want to attack them aggressively. That aggressiveness can occur with additional testing, and it also can come with surgery. So what's the big deal? What do we do? And what is going on? Well, the way that I was taught is it's infection until proven otherwise. Every post total ankle pain or problem, you should have the thought of infection, even if they're completely benign, even if their pain is minimal. And how I work up an infection is similar to probably most everyone else, but certainly labs. They don't show the full picture. So I have a low threshold to obtain fluid from the joint and send it for culture and see what grows back, and also assess for a cell count. And then I'll do special tests. As Justin had mentioned, I rely on CAT scan imaging. I also rely on SPECT CT imaging. And if it's available, you certainly can check alpha defensin and see if that comes back positive. So for me, step one is evaluate for an infection and prove that there is not an infection. So this is a case that I encountered, and I apologize, I don't have the full pre-op x-rays, but I think the CAT scan does it justice here. This is a 70-year-old guy, a little bit husky, an active gentleman. He lives upstate New York, but came down to Long Island. He has seen some of my partners for his knees and wanted me to take over for his ankle. He has obvious arthritis to his tibio-talar joint. There's some varus. He didn't have any symptoms in the subtalar joint, even though he has frank arthritis as seen here. He used to play pro baseball, so he's an active guy, and just noticed ongoing pain to his ankle and wanted it resolved. Went ahead and did a PSI ankle arthroplasty. Seems pretty straightforward. These are post-op or peri-op fluoros. Yes, you can potentially see a little bit of varus, but he did fine. His post-op course was unremarkable. I put a special screw along the medial malleolus. I was nervous about the width, and he did upstate, and he was active on his 25 acres that he had and was constantly doing land work, lawn work, just making sure that his home was as elegant as he wanted to. Comes back in 2 years later, just because he had an injury. He was walking in his backyard, fell into a ditch, and ultimately rolled his ankle, impacted his ankle onto a tree, and was having pain. And I didn't really think anything of it. But after doing the workup, as I had mentioned, there were found to be some small cysts, and certainly you can have cysts that are much bigger. And he and I had a specific discussion on revising this. We tried everything. We tried bracing, and we did not rush into it. The infection workup came back negative. Ultimately, determined him to have some tibial cystic formation, and he was in fact loose. Took him back for a revision, did an in-bone, and he did extremely well. So finding it is key. Recognizing it and not hiding your head in the sand certainly is the most important thing. But tibial component loosening is a major problem. As far as cysts, well, no two cysts are created equal. When you see them, if they are symptomatic, then certainly you want to monitor them more aggressively. But if you see them and they are not symptomatic, they are pain-free, well, you want to make the patient aware and you want to monitor. And then if they become bigger in size, then you obviously want to monitor more closely. But then there will become a time where you're going to have a conversation with the patient to determine whether or not you need to move forward with addressing them. Do they need another surgery, or can you attack the cysts individually and graft them? My choice would be autograft, but obviously allograft, autograft, a mixture, and plus or minus cement can be used. And again, these cysts can come from wear debris related to the poly. They can come from stress shielding. The synovial fluid in a high pressure situation, depending on the implant, depending on the body habitus, can certainly play a role. And then again, those cysts that were there and then you thought maybe the cuts would avoid them, the cuts would cut through them, and you either forgot to or failed to graft them appropriately, can certainly lead to worsening cysts over time. So when attacking a loose tibial stem, you want to know what your options are and what your tools available are to you. Certainly having a full understanding of the situation is key, making sure there is no infection. Feel free to get a second opinion, and I encourage that for all surgeons. Experience is critical. If you do not have experience handling these cases, as they are quite complex, feel free to a partner of yours, whether senior, junior, or one who has more experience in this area. Proceed with caution. The cysts can come from malalignment, and if there is an obvious malalignment, be sure to address them. Handle the deformity either in the tibia or in the talus, or certainly discussion with staging should be mentioned before moving forward, and obviously you never know what you're going to encounter until you're in. Reestablishing the joint line is vital. You don't want to leave it in a poor alignment. You certainly want to use augments that are available with certain revision implants. Unfortunately, we are in a time frame where we have great revision implants available to us, thus creating improvement to the joint line. Stability, you do not want to leave the operating room with any evidence of instability. Soft tissue procedures can help. And then poly. The poly, there are various sizes that can be used. So certainly having a good selection of your sizing for stable motion in the sagittal plane and even in the coronal plane is critical. Poly, stability, and alignment. Wear and tear to the tibia and to the tibial component, even to the poly, is critical, and that is a real phenomenon, the true cause. Do not lead a patient to the operating room without a definitive plan that is a result of the cause of this problem. If it's infection, to possibly stage this, unless you're catching it in a more acute time frame. Septic problems can be addressed with the many revision implants that we have. Loosening, whether that be due to soft tissue or bony, can certainly be addressed. And then our revision implants work. So be sure to have a good understanding and feel comfortable using them. Thank you.
Awesome, Adam. I likewise have a few questions for you. We are going to swing over to Alaska. Dr. Fox is going to bring us and help us understand what we should be thinking about on the Taylor side. Raven?
All right, everybody. Well, thanks everybody for joining, and I appreciate the invite. My name is Rabun Fox. I'm a orthopedic foot and ankle surgeon in the far north, Anchorage, Alaska. Tasked today to talk about Taylor implant loosening, and specifically discussion of advancements in total ankle designs as it pertains to the Taylor side and loosening. So disclosures, I have none. So one of the things as we talk about Taylor implant loosening, and this study just basically looked at a number of different ways that we can define aseptic loosening in the total ankle. And this is just to highlight some of the variability in our definitions that can create challenges as we talk about total ankle loosening, in particular talus, with this presentation. I think this is important to keep in mind as, you know, with the varying definitions, it can create challenges and make sure that we're kind of all speaking the same language with our total ankles. This is an intentionally busy slide with the idea to kind of highlight the number of different ways that we can talk about it. So total implant, you know, historically is a fairly common rate of failure. Obviously, you know, starting with the agility implants, rates of loosening as high as 76%. And these are, you know, likely in large part due to the implant itself, but I think also there's a consideration of, you know, patient selection, technique, and things like that. Yeah, moving forward, we start to see some decrease in that loosening, but still, you know, 10% loosening and 9%, almost 9% subsidence, specifically on the Taylor side in the mid to late 2000s. And then this third study here is in 2020, but it is an older generation of a capped talus design that we'll go into later. It still shows fairly high and significant rates of combined tibial and talar loosening, about even in this study. So Moving forward, these rates do start to trend down significantly. Even in the mid to teens, we start to see this loosening of the star implant. This was reported as 0%, and I think we'll highlight later is that there are some challenges in seeing early loosening with these capped talar implant designs, but still seeing a fairly high subsidence rate. We start moving into the modern generations, we start to see a much lower rate of combined loosening and subsidence for modern implants, the fourth generation, like the Infinity, and 3% total loosening for these similar fourth generation implants presented by this group. The challenges with the newest generation of the longevity or the duration of some of these studies is somewhat limited so far. Obviously, imaging modalities, we're all getting, weight-bearing radiographs for follow-up, and that can certainly tell us, a large part of the picture. However, again, we'll talk about this here in just a second, is that on the talar side, in particular, the generation of implants such as the Star and the Salto made things really challenging with regards to seeing early loosening and anything that was happening underneath that capped design. This radiographic evaluation in this came with significant limitations and intra-observer reliability issues. So moving forward, and this is kind of a similar study, obviously, as already presented, the SPECT CT is very helpful and has been shown to correlate very well with intraoperative findings for really as a sum total with kind of all intraoperative findings, but certainly in this generation of implants, it can really help really understand what's happening underneath these capped implants. And here we have a highlighting a Salto total ankle that has that lateral chamfer cut that you have to make that can be hidden or that can hide sometimes under the implant. Before we talk about the implants themselves, I think it is important to talk about how we put them in. This is a very well done, a very good study just in terms of technically identifying some of the risk of blood supply and obviously, risk of some segmental blood supply injury to the talus would have obvious implications on bony ingrowth to our talar implants. And on the left, we have the illustration that the M-bone reamer rod they obviously insert can show clear injury to this artery of the tarsal canal. This deltoid branch here in the center picture, more commonly with the Star implant that has this medial chamfer cut. And then the other implant they looked at was that Zimmer, just the lateral entry and the potential implications of that fibular osteotomy on injury to that perineal perforator artery. So before we get into the implants themselves, the discussion of total implants and obviously has come a long way from these kind of implants that really did not respect much of the anatomy or have great understanding of the anatomy or the biomechanics, and towards moving towards these essentially resurfacing where we've it's gleaned a lot of and really gained a lot of information from our hip and knee partners, and even particularly with this implant in the center of the the Exactech one, even from a total shoulder literature or experience that they've had. So speaking of metallurgy, so some of the earliest of implants were all titanium. We moved obviously to a cobalt chrome bearing surface. And this has a significant bearing on polyethylene wear and things that were already touched on to degree. So obviously with the bony ingrowth surface, early designs were more of a porous coating on all the way up to agility. And then we moved to a titanium plasma spray that has a better properties for bony ingrowth. And then really the particular implant shown here has kind of started to move towards much increased surface roughness, which can assist with time zero fixation and potentially mitigate some of that micromotion at the interface that can cause the lysis. Starting with the agilities, we've got, mostly anatomic implant here, but a very small footprint of that talar implant that can result in a high rate of loosening as the limited fixation from just that single central keel is shown here. You can see this really is a small footprint that required a lot of cuts and a lot of potential injury to that talar side. And that is shown with a very high rate of loosening that's shown with the agilities. Moving forward to the star and the salto, kind of similar in some ways with regards to the medial or the lateral chamfer cut. Both have this kind of more of a cap design to a degree. This can result in and lead to stress shielding just from the amount of stress being dispersed very broadly. And as we all know, that bone remodels secondary to and as a result of the forces that it sees over time. And so this can create issues with that stress shielding. Additionally, as we spoke about earlier, the design and the capped nature of this over the talus can result in some difficulty seeing early lysis or loosening of the implant that could be caught early and potentially result in not quite as extensive of a revision surgery. So a couple of highlights from those technique guides. You see the star on the left and then salto on the right. So salto really only has that lateral chamfer, but still significant into that lateral gutter and into that lateral process at times, depending on how you do that cut with a reciprocal saw. And then the star, obviously, here with this kind of capped design with that single central keel. To highlight that, a retrieval study here showing a star with very little bony ingrowth on the backside surface and that cap design, as you can see. And you can see how that would be limiting and just the volume of that bony ingrowth surface, maybe potentially leading to that stress shielding. None of the retrieval studies really showed the salto, but again, highlighting its design. The old generation, this was radiology journal. It showed that 200, about an average of 2.5 years, a total of 262 implants, mostly agility, but moving into some of the saltos and the stars. We see a 33% rate of loosening, 11% overall on the talar side, and fairly significant, obviously, which would indicate loosening as well, at 24% subsidence rate. And obviously, these numbers are pretty striking and pretty significant. Now, something is important to note is that not all of these end up requiring surgical intervention for revision. That being said, it's still a fairly high number. And then again, just to show subsidence and losing of that salto type of implant. Moving forward to the new generation, certainly this is not an exhaustive list of everything that's being used now, but more of the implants that fall into the design of this kind of resurfacing of the talar side with the chamfer cuts. So just kind of highlighting a few of the designs for the cadence and the new Paragon apex, this advantage, that central keel or that central. And then, so, to highlight again, we showed the salto and star and the technique guides, and then to highlighting here, instead of these chamfer cuts and more aggressive cuts, we've kind of gone to the more kind of anterior chamfer reaming, and then small amount of resurfacing cuts done on the superior surface, as well as that posterior surface, that limits the amount of bone resection and limits the amount of cuts done on the talus to decrease that overall surface area. Again, to show some of the other newer implants here, and this idea of checking the chamfers and make sure all the things are smooth as part of making sure the fit as well. So moving forward into some of the data on the newer studies and kind of illustrating the very large advances or very significant advances we made in loosening. Again, to highlight that overall studies on these newer implants are shorter and a little bit more sparse with regards to this specific topic due to the nature of that haven't been around quite as long. This was a good study out of HSS, I believe, published in FAI. Non-inventor looking at this happens to be the cadence, now Smith and Nephew. Average of 3-year follow-up, minimum of 2 years, 48 total ankles with only 1 revised for talus loosening. 0 at the final follow-up that made it to final follow-up had any evidence of lucency on the talar side. Important to note that the one that they did revise for loosening also had a concurrent talonavicular arthrodesis that went on to need to be revised. So there's certainly somewhat of a confounding there. Last study here, just looking at the new generation overall, minimum 5-year follow-up. This is actually I have a different group, but the same group out of HSS and then NFAI, looking at minimum of 5 years, standard radiographic follow-up against no spec CT or no higher level studies and imaging. That being said, overall, very, very low rates, and highlights the sharp decrease in overall rates of loosening on the talar side. Only one with loosening of isolated talus and one with combined loosening. No other implants at the final follow-up had loosening. So to highlight, obviously the sharp decrease in the loosening rates is positive and something that gives us a lot of hope going forward with regards to outcomes, and hopefully this holds for longevity of these fourth generation implants.
That's awesome. Thank you. Mine's going to be a little bit more of a potpourri, and we'll go through some issues. And my perspective is that I've been doing total ankle since 1998. And the graying of my generation is real. And there's some lessons through the years that have gotten carried on. And some of them maybe ought not to have been carried on. So my disclosures, I'm a consultant and I royalty bear on Stryker, total ankle. And then potentially we might talk about osteo. So old days. So I'm calling this early to mid 2000s. This is what we looked at. We would do a triple arthrodesis followed by a total ankle. And the rationale was that our implants were so poor that we just had to have a perfect foot. At least that's what we thought. We thought we were optimizing to enhance longevity. Well, now in 2024, if at all possible, I avoid the hindfoot fusion. It's my opinion that if we maintain motion, it decreases load on the implant, it improves patient function, it improves patient satisfaction, and it makes care decisions much more efficient when you're not doing all that extra surgery. That's not to say that I ignore deformity. I just think about it differently. Only about a third of total ankle cases have normal alignment, but using modern tools like Prophecy to help me focus on getting my implant aligned correctly, and then I allow the foot to physiologically accommodate. So I still do hindfoot fusions. So if you look at the one, you look at the one on the left, you look at the one on the right, I did the same surgery, talonavicular fusion along with an infinity. But on this one on the right, even though you've got all that edema and extends down to the subtalar joint, I'm very hesitant to fuse that subtalar joint. And this isn't a new idea. So this is Duke research coming out of 2014. They had 404 consecutive total ankles. 70 of those had a hindfoot fusion. So 17% rate of hindfoot fusions. And total ankle performed with ipsilateral hindfoot arthrodesis result in significant improvements for patients. So it's not that hindfoot fusions are a bad idea. But if you look at overall outcome scores, overall outcome of total ankle plus fusion was inferior to that of isolated total ankle. So the moral of the story is, if you can just do the ankle, not have to do the hindfoot fusion, you and your patients are probably going to be better off. So the potpourri I've got is this persistent hindfoot pain that we've been talking about. And I've got some cases to help us work through this. Some of these cases are pretty tough, but I think they make some points. So we're going to look at total ankle that still hurts despite what looked like good x-rays, hindfoot fusions that still hurt, and then combo fusion and total ankle that still hurt. So case one, this is total ankle, and the concept is that the pain might not be metal. And this was a revision total ankle with excision of heterotopic ossification. So HO's pretty common on radiographic review. It is across all implants. We did a study once, which we published in FAI, and we compared InBone, which you all know we ream, compared to Infinity, compared to Star. And we wanted to know, is there a difference in HO rates? And the answer was no. So here's my patient, 56-year-old director of IT. You can decide if you like her or hate her. She was head of our EPIC adoption program at our hospital system. So she has chronic lateral instability. I've done a total ankle with ligament recon. And here she is at 1 year, which I say, hey, looks pretty good. Well aligned, fully ingrown, no evidence of gutter impingement, should be great. But the problem is the year was tough. She was in my office every few weeks because she had real pain. It was a diffuse pain. She had a really hard time to describe it, and her motion was getting worse. So we were working through therapy. She had extended therapy. Motion was going down, down, down. And if you haven't seen it, this is the face of HO. It's the patient that has persistent inflammation, decreasing range of motion, no obvious X-ray explanation of it. And the reason is your HO is maturing over the course of the year. So modified Brooker classification for HO starts in the ankle, starts with 0 and it goes up to 4. 1 is just islands, 2 is less than 50%, 3 is more than 50%, and then 4 is complete bridging bone. The example on the right here would be a Brooker stage 4. We published in 2022 looking at 90 infinity and cadence, and what we were looking at was 2 years. We picked 2 years because HO is usually pretty mature at 2 years. We are interested in the location and the incidence of HO, and we used this Brooker classification. What we found was HO is most common posteriorly, grade 2. So remember, less than 50% top to bottom is the most common, and we found no difference in implant types. So my approach to HO, first thing is wait for it to cool off. You got to recognize what it is because you don't want to operate in the middle of HO because it's highly inflammatory and it will be very painful for the patient and likely unsuccessful. Second is use CT to define the location and the approach. Sometimes you have to go posterior, but my usual approach is an anterior approach. I pop out the poly, I cut the posterior bone along it, I tease it off the capsule, and I bring it out. Preventing HO, I have tried everything, and I have nothing to recommend to you that I can prove works. I've tried thorough irrigation, which I still do. I did post-op radiation for probably a year and found nothing. I didn't even publish the paper because it didn't show anything. We've used amniotic tissue. I'm not convinced it works. We use oral steroids. We've used injectable steroids, and we've used early motion. So I think HO is one of those. You just got to kind of know that it's in our world and then address it. Second case, persistent pain following hindfoot fusion. So this is kind of one of these ones where it's just too darn stiff. And you got to create a motion segment because the patient just hurts too much. So this isn't super uncommon in my practice. I do ankle fusion takedowns probably once a quarter. But this is Murray Penner's case. So you'll see the frustration that goes as this case builds. So 58-year-old work comp, construction worker, falls off a ladder, open pilon. He had an IND, XFix, ORIF. After 4 surgeries later, he had an in situ ankle fusion. I think most of us would say pretty good technique, compression screw, anterior plate, but he still hurt. So then syndesmosis fusion because he lit up there on a SPECT scan. No better. Subtalar fusion 1 year later, now 3 years out from his ankle fusion. But it went on to a non-union. So they revised the subtalar fusion. The leg is too stiff. The whole thing's healed on CT, but it's just a miserable situation because it hurts. And the SPECT scan on this one lights up on the tibial shaft. It's just all the weight being transferred up. So if you're going to do a takedown, what's the criteria? Well, Hansen had this criteria, clearly defined source of pain. In this case, his tibia lit up, intact malleoli, and intact lateral malleolus. Hinterman, a little bit different. He said, don't ever do it if you're missing the fibula. Don't ever do it if you have valgus. Make sure that you have good soft tissues. So if we take a look at our patient, he has salvageable limb. He had a lateral malleolus and good tibial bone stock, good talar bone stock, ligament stability. So he's a candidate. So this is the way we'll play it out is we'll do a CAT scan, run it through the prophecy treatment. That will generate a number of guides. On these prophecy plans, you can see where the ankle scar was so that you can draw this out and set the alignment of it. You're going to then guide it. Remember, you have to extend the gutters when you do the surgery. The prophecy guide is going to have you, in the cut blocks, you're going to have you cut out a block. You have to hand cut those lateral malleoli and then deliver it. This is the same case 4 years out, and done very well and resolved the pain. So case 3, this is one that I am really just working on now. So this one's kind of fresh. And this is a guy who had persistent pain following hindfoot fusion and total ankle. And the concept is work up to try and sort out the pains from the total ankle or from the hindfoot fusion or both. This is a revision subtalar joint fusion with revision talar implant. So he's an executive, long-term ankle pain, limited to his golf. Injection gives him 100% relief. So we're confident that this is an intraoperative thing. He has a valgus total knee above that his total knee surgeon is unwilling to do. So this is what he looks like. So I did inbone 2, very uncommon, but somehow I found a way to break the medial malleolus. So I fixed that, but otherwise, good looking implant. 1.5 years post-op, he gets an infected toenail and he gets a new fever. Thankfully, he got into me. I tapped his ankle and is positive for pus. So this is super acute infection, less than a week. I took him to the OR. I washed it out. I kept his metal implants. That is a cement spacer in between the metal implants. And I did that based on the fact that I caught this within 5 days. We took out the hardware while we were there. At 12 weeks, everything's negative. 12 weeks, I reimplant the poly and the hardware is out. So here I am, revision 1. Just the fact I'm calling it revision 1, you can smell what's coming down. So 3 years later, is he starting to hurt again? So now we're 4.5 years post-primary and he has subtalar joint pain. CT shows that we've had some collapse on our talus and we've got subtalar joint DJD. Remember, he had an acute infection. So like Adam says, if it looks and smells like infection, better make sure. So I did blood work, which was normal. Aspiration was normal. ID said chronic infection unlikely. But remember, he had this history. So I revised his talus. I went to an in-vision. I said a subtalar joint fusion. All cultures were negative. I'm pretty proud of myself at this point. I think we're doing pretty darn well. Post-operatively, we follow him out. Everything says this is healed. 3 months, 40% fusion, over 50% fusion at 1 year. No swelling, no pain. He's back golfing with his buddies. Now, by the way, he plays golf at my club, so I get to see him all the time. So 2 years post-revision, pain slowly coming back. It's lateral based. No new lucencies. They're giving me a little bit of a different read, and they're saying at 33%. I'm not sure how it goes from 50 to 33, but that's what they're reading. And this is what his CT looks like. And it clinically is kicking up into valgus. So something's going on. I wait him out another year, and now it's coming pretty obvious. This CT doesn't really show it, but what he's got is he's got some spot welding in his anterior middle facets. His posterior facet is just not fused, and you can see him kicking out into valgus. So here we go again. I worked him up, a repeat white label bone scan negative, normal blood work. I actually did an open biopsy of his subtalar joint, which was negative, sent him to the Mayo. They did it all again, agreed it was an infection. So this was my case last week. So what I've done is revision subtalar joint fusion. All cultures are negative so far. I have fused his tail navicular joint so that I've got an Envision implant now extending up to the talus. You will notice that I am seating my talar implant on that calcaneus on the back. I've got him out of valgus, and I'm optimistic. So if we look at what our goals are in hindfoot fusion surgery, or in hindfoot surgery, not fusion, is pain improvement, not cure, functional improvement. I'll argue delivered in an efficient manner, and I'll argue although stage surgery is sometimes necessary, I try to avoid what I call the stiff straight leg, where we're busy patting ourselves on the back as surgeons and the patient just doesn't have a great result. When the leg still hurts, rule out the dangerous diagnosis of infection, rule in the most common cause of persistent pain, and our panel has walked us through all those. Decide if anything can be done with a reasonable chance of success, because sometimes you're better just leaving it alone. And remember to empower your patients with knowledge and use shared decision-making when you're getting into these really tough cases. Thank you. Just a reminder, this will be posted up on Foot Innovate when this is all done. All righty. So, you guys ready? All right.
Yeah.
So I'm going to go, I want to start with gutters, guys. We've got about 9 minutes to do this. So Justin, do you prophylactically debride your gutters? And if you do, how?
I do. And I'll basically, you're looking right at it. I think it makes sense to address it at the time. And so, I'll have everything on hand I need, in particular, a pituitary rongeur. And I'll just make sure I can see that on the sides of the tailor's plate, I don't have too much bone. I kind of use the borders of my tailor implant as kind of a judge as to how much a bone is protruding. And so basically I try to make that as flush as possible. I even try to, this is just anecdotally, I try to make sure I can turn my pituitary rongeur within the gutters kind of 90 degrees just to make sure there's enough room over there. And then radiographically, I'll take some images just to make sure there's nothing obvious impinging in the area.
Okay. So Raven, I like your studies that you quote, that blood supply. We kind of think about that. If you're debriding gutters, do you prefer to take it off the talus or off the malleoli, and why?
I think it feels more natural to take it off the talus, just because you're there looking at it and you kind of use that medial or lateral as a guide. That being said, a lot of the ones that I don't know if it's just recency bias, but a lot of the ones I've done, they have that little extra ossicle in that area underneath the medial malleolus, and I end up taking that out and then feeling more comfortable with the level of debridement of the gutter. But usually it kind of is a combination, but it oftentimes feels more kind of comfortable to take it off just with that into the implant on the tailor side.
Okay, cool. Adam, can you throw in your experience on gutter debridement and how you think about it?
Yeah, I just over resection because I've seen that coming from others. So I use the side of the implant as mentioned, but then I'll also kind of put the rongeur in and grab and hedge more towards medial mal. So I'm getting bone there versus taking off too much talus. Then you have a potential rocky point for your.
That's great. Yeah, one thing that I'll caution everybody against is a externally rotated post-arthritic ankle and thinking that you're going to correct the deformity by internally rotating your implant. That is a recipe for iatrogenic impingement, and you'll create gutter pain. And that's one thing that's really interesting. If you haven't read any of Andy's work on rotation, looking at guides and total ankles, it's really, really interesting to look. But I agree with all of you. I'm pretty aggressive on my gutter debridements, and I do that because I want it free, but I also think it lets me miss in rotation just a little bit, and it does a little bit more freedom. And I'm 100% fixed bearing now. I don't do any mobile bearing just because I think we're way better at rotation than we once were. All right, Adam, I agree with you. I think bone quality is a big deal, and I don't think we talk about it enough. How do you look at preoperative bone quality, and is there anything that sets off little alarm bells?
So I have a low threshold to order an MRI because I think the MRI will show other. CAT scan may not. The CAT scan may show evidence of cysts. The CAT scan may show some evidence with an X-ray, also some evidence of osteopenia. So I add the MRI. Then I have that discussion on bone health based on your age, and I have a low threshold to getting our bone endocrinologists involved, our metabolic endocrinology consultants. So I'll be quick, but bone metabolic endocrinologist for a workup. I don't know where I lost you.
Okay, no, that's good. What do you think, Justin? Do you have any, if I give you the theoretical patient, they're a great candidate for total ankle, but they have this, what I call cystic arthritis. Does that influence your technique or implant choice?
Yeah, not my technique. I think I'm just a little bit more careful. I'm kind of a chicken with those, and I think I'm just basing it off past experience and a failed total ankle in that exact same situation. So, I think I have a conversation with the patient. I let them know that if they want to, we could certainly push forward with it, but I would often maybe err on the side of fusion.
Okay. Raymond, any experience with the cystic patient?
Yeah, I think in the cystic patient, the way you just depends on the level and location. I think with some of the low profile implants, obviously you have to start thinking about in bone on the talar side. On the tibial side. On the talar side, depending where that cyst is, if it's really in the dome, then you potentially get underneath it with just a flat cut, and then also kind of getting a sense of where it is relative to that central peg. If you're going to use the in bone style implant, or one of the tibial implants that has talar implants that has the larger central post, like that can fill that void. Small amount of grafting, things like that allow you to extend a little bit of the life or a little bit of the options of what you can do from a total ankle replacement versus ankle fusion.
That's great. Thanks. I agree. There's a study out there that I can't quote for you right now, but it looked at pre-op cystic disease, and we cut out about 70% of the cysts on average. So that's first point is that there are going to be cysts left even when our ankle's in. Second point is I think there are cyst makers. And so if they've got a lot of cysts pre-op, they're more prone to cysts post-op. And for me, that means a stemmed, not a peg, but a stemmed implant all day, every day. All right, our fearless leader's back on the screen. I think he's given us the hook.
Awesome session, guys. Fantastic. Lots of good questions and great advice. Appreciate your time, guys.
Yep.
Thanks.
Now you guys can go back and watch the Masters.
Thanks, guys.
All right.
Appreciate you.
Talk to you later. Bye-bye.